So remember, this patient that Ioana just presented with those hemodynamics, that hall walk, came in on sildenafil at a dose of 20 milligrams 3 times a day. So I want you to tell me what you want to do now that you've done an accurate cath, you have the correct diagnosis. Do you want to continue the sildenafil monotherapy but increase the dose to 40 milligrams? Do you want to discontinue sildenafil and start riociguat? Do you want to start a 2-drug regimen, escalate therapy to include an ERA or a PDE, prostacyclin analog, in addition to the sildenafil? Or do you want to switch or start and move on to an IV or subcutaneous prostacyclin? So we can see right off the bat that 3/4 of our slides are not going to be shown. It's a pretty much of a consensus here that want to go to a second oral therapy. So let's click that box and see where it takes us. So this patient, this Ioana presented PAH, scleroderma, PVR of 7.9 to start out with, was started on macitentan, or was added macitentan 10 milligrams in addition to the sildenafil. And 3 months later, she feels a little bit better. Her echo is moderately better, but her right ventricle is not perfectly normal yet. It still has some right ventricular enlargement and dysfunction. She has functional class 2 symptoms, and her BNP is still elevated at 170. So she has some things still in the moderate risk range and some things that are lower risk, like her functional class. Here's her echo. Her RV is not perfectly normal, but it's certainly not the worst right ventricle that I've ever seen. It's maybe a little bit big, maybe a little bit down, maybe her right atrium is a little bit big, but overall doesn't look terrible. So let's talk about what the evidence is for combination therapy in this patient. We escalated to combination therapy, and Rich, do you want to start off talking a little bit about that?
Yeah, so there have been several studies now looking at combination therapy, consistently showing benefit. And this is the Ambition trial, which was upfront combination. So not exactly like our scenario, but clearly showing that, in this case, patients started on Ambrisentan and Tadalafil as an upfront combination was associated with better outcome in terms of the primary endpoint than monotherapy. And this was time to clinical failure. So it was prevention of worsening, but also reaching a low risk or a class 2, what you might call a lower risk category. And the combination of those 2 drugs was clearly beneficial with those hazard ratios you can see here.
And I think it's probably likely that if any of us had seen this patient, that they weren't started on therapy in the community, that they were referred in and we made a fresh diagnosis, that we probably would have taken such an approach on this patient up front. Would you all agree? Okay.
Yes.
There's also data suggesting that combination therapy can slow the course of the disease and delay hospitalizations. Vic, you want to take us through this sub-analysis from the Seraphin study?
Sure, Val. So Seraphin's a big study looking at our third ERA approved for use now, and we studied a couple doses of macitentan and looking at a clinical endpoint. And what we found was, and important here is these are prevalent patients already on a background therapy. A significant proportion were on at least one background therapy. I believe about 60%. Not 2 background therapies, but 1 background therapy. So I think what you can see here is the patients that the placebo patients more often had an event, and patients on 10 milligrams of macitentan did the best when considering first all-cause hospitalization. So we have another study here in patients already on a therapy, like our patient was, who had an additional therapy added and did much better than if placebo was added. So again, more evidence for being a little more aggressive up front. And again, here's a slide looking at patients on background therapy. And so this y-axis now is patients without an event, keep in mind. And you may not, I don't know, you can see the colors there, but the bottom line is patients on macitentan were less likely to have an event. So again, we got pretty good data suggesting in patients on background therapy, adding an ERA was a good thing to do.
Right, and that is really consistent with our patient. And we have even more morbidity and mortality outcomes data. Ioana, do you want to take us through the Griffon study?
Sure. So the Griffon study enrolled patients on no background therapy, 1 oral monotherapy or dual combination oral therapy, and randomized them to selexipag versus placebo. Of note, the vast majority of patients had background therapy. A third were on dual combination already. So the vast majority prevalent patients, and this is the main endpoint, which showed that the selexipag patients had much less, significantly less events in the primary endpoint compared to patients who were already on placebo, statistically significant, and there was a 40% reduction in combined morbidity and mortality in the selexipag group.
Great. So let's reassess what this patient's risk category is. And Ioana has shown you this table and has really highlighted the fact that sometimes patients fall into more than one color, right? Sometimes they have a couple of low risk factors and a couple of intermediate risk factors, and we kind of have to blend that in our head and figure out what is the best thing to do with this patient. So this patient is now on dual oral therapy. The hall walk has improved, 405, functional class 2. The right ventricle is better, but not entirely normal. BNP is still a little bit elevated. So what do we want to do? Are we happy where they are? Do we say, gosh, you need an additional therapy? You need 3 therapies? Do we want to start a prostacyclin, a parenteral prostacyclin? Or do we say, gosh, we want to list you for lung transplantation? All right, so you guys have to vote because what the next slides are going to be entirely dependent on what you choose. So, that one wasn't as unanimous. So there were some folks who wanted to continue the plan. So, Rich, is that an unreasonable thing to do? Tell me what you think.
I don't think it's unreasonable, but I think with the data that was shown, you're putting a patient at a higher risk for an event down the road by not adding a third drug. And the Griffin trial showed that. So how much risk are you putting that individual patient at? It's hard to say, but you're decreasing the risk by adding another drug. And the concept of looking forward at future risk, I think, is a very important one. So, if you kept them and just watched them very, very closely, that would be an option, but I think we really need to take a more aggressive approach.
There's this very famous PH doctor that I know that says you can do anything you want to a patient as long as you watch them closely enough, right? That's Dr. Tapson. What's your opinion?
I wouldn't quite go that far.
Well, I agree with Rich. But I do think there's some sense to be you can do whatever you want to a patient if you watch them close enough. This means you're calling them, you're talking to them, you know their trends, obviously within reason. You're not going to just watch them.
Right.
If you watch somebody and pay attention to how they're doing and their trends, you might be able to follow this patient longer and make a decision. Maybe in another month they're doing even better. But I agree with Rich. I think our tendency nowadays is to be a little bit more aggressive up front, try to reach those patient goals, try to get the RV normal, the BNP normal. There's a study now ongoing, the Triton study, looking at Tadalafil, macitentan versus Tadalafil, macitentan, selexipag up front. Triple drug upfront therapy. Maybe we'll learn more about upfront therapy in that situation. Now, this isn't upfront therapy here, but we got a little more to learn. But I think the bottom line is we tend to be more aggressive. If you're not going to be more aggressive here, we'd want to pay close attention to this patient, follow them closely. But I would certainly agree with what most of you guys said. This patient's not ready for transplant and not ready for parenteral prostacyclins.
Right, and I think that's one of the wonderful things about all the choices that we have these days compared to 10 or 20 years ago, that we don't need to entertain those transplant IV options in a patient that has some yellow and some green. So this patient, as you guys voted, was started on selexipag, started at 200 mics twice a day and titrated up to 1,000 mics twice a day. Ioana, do you want to just say a word about how you titrate selexipag and the dose response issues related to that?
Yeah, so Val, we've learned from the clinical trial and then from using in practice in the past couple of years to start at the lowest dose, which is 200 micrograms twice a day, and increase typically once a week if patients tolerate by 200 micrograms twice a day, up to the maximum of 1,600 micrograms twice a day, or until they achieve side effects. So the goal of increasing and up-titrating is very similar to how we do it with intravenous ibuprostanol infusions where we push the dose until we get some side effects. And if the side effects are very severe, then we back off. If they're mild and they're tolerable, then we stay at that particular dose.
Right, and the trial showed that as long as you push to the highest tolerated dose, whatever that was, the 3 different dose groups, low, medium, and high, all had the same benefit. So if this is what the patient tolerates, if that's their highest tolerated dose, that's okay. So she's currently on Selexipag, Sildenafil, and Massey, and after another 3 months, she's clinically stable, her hall walk improves a bit, she's functional class 2, and her echo is unchanged. So what are you thinking now, Vic?
I'm thinking we did okay here. I mean, I'd like to see her, her walk be a little bit better. I'm really glad she's functional class 2. That's really important. In fact, her echo's unchanged. I mean, it's not worse. I'd like to see the RV normalize, but maybe we need a little more time. Maybe we should go up under sildenafil. We don't have a lot of data on what to do with sildenafil, right? We looked in the original study we did with sildenafil. We found that 40 was probably better than 20. 60 may be better than 40, but it wasn't statistically significant. Still, my guess is most of us probably tend to go up on the sildenafil dose if tolerated. Is that right? Would you guys agree? Would you consider that, or what do you think?
Yeah, absolutely.
So let's talk a little bit about that more aggressive therapy that we've referred to. You know, Vic had mentioned the Triton trial. There's actually very little data with upfront triple combination therapy. This was really an observational study that was done by the French in kind of a critically ill patient, a very serious population group, but it's the best upfront triple therapy combination data that we have. Rich, do you want to walk us through this?
Yeah, so very briefly, these are patients, as you said, were quite ill, severe RV failure, and they were going on epoprostenol, but in addition, they used 2 oral drugs, the ERA and a PD-5. You can see the protocol there. And then they basically reported on the outcomes in those patients. And you can see here this very dramatic improvement in hemodynamics. Look at those PVRs down under 500 dynes and PA pressure down. So this is sort of a home run when you're getting to a benefit. These patients went from near death in some cases to really doing very, very well, almost miraculously. And not proof of the benefit of triple combination over, let's say, IV therapy alone, but certainly looks pretty darn good.
Right, and I think this has become more commonplace now in those patients that we get that are really sick, you know, that have a lot of things in the red zone, that are functional class 4 in RV failure with a cardiac index of 1.8. Those patients that we're going to start on parenteral prostacyclin therapy. I would say my practice is very similar to this now. Those patients that are that sick that we put on IV therapy, we also add on both classes of oral therapies. Iwana, Vic, Rich, do you do the same sort of thing in those folks?
Yes, we absolutely do. Recognizing the lack of randomized controlled trials in this very sick population, we have to rely on, cases like those presented by the French registry.
Okay, so let's go on. Our patient, another 3 months later, is clinically stable, hall walks a little better, still functional class 2, echoes unchanged. So I would say, gosh, I think most of us are reasonably happy with this. Vic, how do you follow such a patient, and then what's the trigger to say, gosh, I need to do something more, go on to parenteral therapy, consider transplantation?
Well, in this patient, I'd probably still see this patient every 3 months. I personally wouldn't have a repeat cath done. Some of my colleagues might. I think if you follow the patient's history exam, 6-minute walk, BNP, and echo closely, and there's no diagnostic issues, I wouldn't do a repeat cath.
Wait, I'm going to stop you there.
Okay.
I want to take a poll. I would, like, when she is on triple therapy, I would recath this patient. Rich, would you?
Yes.
Okay. Iwana, would you?
I will go with Vic.
Okay, so it's a tie.
All right.
It's a tie. Okay.
Thank you.
All right, go ahead, Vic.
Oh, was I still? Oh, yeah. So I wouldn't recath, and I'd follow the patient closely. I might have a low threshold to go up on the PD-5 inhibitor. I wouldn't start this patient on parenteral therapy unless something really changed. I might consider it. But to me, parental therapy is reserved for sicker people. And as long as this patient was doing well, I might sit around and wait for another drug to be approved. Who knows? We've got a couple clinical trials ongoing with other drugs with different mechanisms. Who knows? But to me, the key is following closely and making sure there's no trend to getting worse. I might consider, depending on the patient, I'd have a low threshold for pulmonary or cardiac rehab, depending on the patient's doing. Those are some of the things I'd consider.
Okay, great. So, Vic already commented on some of these things. Rich, is your approach any differently? How often would you see a patient like this?
In the range of every 4 months, 4 to 6 months, depending on stability, with all the usual follow-up testing that Vic was describing. The question on here about incomplete diagnosis and referral center is definitely a problem, and I think this case really underscores that.
Yeah, I mean, sometimes patients are out there, on monotherapy. So I think one of the points that Iwana wanted to make is sometimes the diagnosis is not right based on echo alone, and maybe they shouldn't even be on a pH therapy. And I think oftentimes when patients come in, we stop therapy not infrequently because we do cath them and their wedge is high and it really is HFpEF. But I think one of the important points is we have so many therapies now, we have opportunities to get people to goal. We want to get that done relatively quickly. We don't want to take 3 years to get the patient to goal. Okay, so just a few concluding remarks about that. In 2018, too many patients are still diagnosed without the complete diagnostic workup. I think at all of our centers, we get patients who are started on therapy based on an echo alone without anything else. And we have the tools to be able to make the correct diagnosis. If some of these studies can't be done in the community, working with a pH center to get the accurate diagnosis, I think is really an important issue, an opportunity for collaboration between the community and the centers. Once diagnosed, I think the most important thing we do is get patients to a low-risk category. And there's lots of ways to measure risk. We've highlighted the ERS-ESC table in this discussion, but there are other ways to do that. One can use a REVEAL risk score. One can use the French approach of just counting the low-risk variables and try to get them to 3 or 4 of the low-risk variables. But the important things are to assess functional class, physical exam for right ventricular failure, exercise capacity, most often with a hall walk. Some folks use CPET, and really trying to get them into the good hemodynamic range. And Iwana highlighted this. Good hemodynamics is more than just PA pressure. And in fact, sometimes even when we very aggressively treat patients, the PA pressure goes down 20%, 30%, 40%, but it often doesn't normalize. The patient is going to do well if we can get that right ventricle functioning better, if their cardiac index is in the normal range, and if the right atrial pressure is in the normal range. And we now have a host of data to suggest that more aggressive therapy, either upfront or sequential, is more likely going to get us into that low-risk stage. Unfortunately, for whatever reason, and there's probably many reasons, many of our patients aren't in that low-risk stage. They're on suboptimal therapy. We certainly have the opportunity with the therapies that we have in our armamentarium to escalate their therapy and try to get them in that low-risk state. And in general, we wait too long before starting a prostacyclin. There's lots of data from REVEAL and others showing that patients, even sick patients, functional class 3 patients, sometimes even functional class 4 patients, go on to have events, including death, without going on to a parenteral prostacyclin. And I know many patients think of it as very scary, and maybe not all physicians are very familiar with using it, but it's really a very effective means of therapy in getting a patient who is still in a high-risk category on oral therapy into that low-risk state. So that ends the case. So just to go through, so you guys took us down, let's see, moderate risk. We didn't go down either of these pathways. Here was the pathway if you were going to just keep sildenafil monotherapy and the patient declines, they're at high risk, and we had a lot of different options of what to do to them, really highlighting the fact that probably all of this was too late. We may not have been able to get them into the low risk category. The second option was to change the sildenafil to Rio. There's some observational data on that, but in a patient who's not at goal, there's certainly a number of other therapies that have more evidence base than that switch that one should have gone to. So similarly, therapy gets escalated, but maybe in not as timely of a fashion, and maybe we don't get our patient to the risk we want. Here is the option that you chose. So we went down this pathway. You started another therapy, and then you actually went into triple therapy. So you got the patient in the most likely path to low risk. So you guys actually did a really great job amongst the options. And then there was an option to go straight to a parenteral therapy, which is fine. It gets a patient to a low-risk category, but there may be less invasive opportunities to do that. So this was really fun. I've never done something like this before. Like literally, we had slides for every single scenario, and you guys chose the path, and I hope it was a learning opportunity for all of you.